Hello again, everybody.
Where are you headed, Cheryl?
Where would you like to sit?
I'm
Doesn't
good
matter.
here.
There you go. She's a little taller than me, so we'll have her go on my left. Did everybody have a nice lunch? Same. We're I hope more people will start shuffling in, but we're just gonna maybe talk a little bit about what this breakout session is. And if you wanna come up closer, that'd be great. Come on up. One of the things that you will need too is a piece of paper, because we are going to start with an activity and you need to write something down. So if you don't have a pad of paper, grab one off of one of these tables and a pen, because we're gonna have you do some homework. So as you all know, my name is Cheryl, but we met Michaela in Nashville, and she did a session on palliative care, which can sound really scary to a lot of people. So what we want to do today is share that palliative care can be such a beautiful journey. So do you want to introduce yourself and sort of say where you're from, and then we could go into the activity?
I'd be happy to. It's an honor to be here. I am so thankful for the invitation and to Cure Duchenne for asking me to be here. I love getting to meet people. That's my favorite part of my job. So thank you for having me. I'm originally from the New York City area, but moved down to Nashville, where I currently live for my training in pediatrics. And that's where I still am. I moved away for a year to do my fellowship in Ohio in palliative medicine, and then the Lord brought me back. So I've been in Nashville for a while now, and I'm thrilled to get to do my work and to share it with all of you.
Right, and as you all know, we do workshops and sessions throughout the year, and we meet some amazing folks at these different sessions, and oftentimes we'll be like, hey, they'd be really good for futures. And so that's how this whole thing started. So I'm gonna put my glasses on so I can see my notes. You can see my notes are right here. So we're going to do an activity, but before we do that, I wanna just take a few minutes, have everybody settle in, relax, chill out, close your eyes for a moment, take a few deep breaths. We had a lot of science this morning.
We did.
So just take a few deep breaths. And what we'd like you to do is reflect on what the future means to you right now. We're at Futures, right? So we want to definitely look into the future. And this is one of the activities that Michaela and I came up with is we would like you to take one of the pieces of paper that is around you, and we would like you to respond to this question. When you look to the future, what do you hope for? What is your hope for the future? It could be about a hope, a fear, a memory, some peace, sadness, or anything that really comes to your mind. You know, everything's anonymous, so be as open and honest as you would like. And then once you're done writing all that down, we're going to have one of my beautiful assistants in the audience is going to bring some of the answers up, and we're just going to kind of read over them a little bit, and you know, sort of just kind of share sort of what some of the thoughts are for a future. So grab a piece of paper. Write down what you hope for in the future. And this was something that you thought was kind of cool because you do like to look into the future at your clinic, right, with your guys?
Yes, absolutely. I like, and I'll show you this too in my slide deck. One of the questions I often ask is, you know, do you like to think ahead, or how far ahead do you think? Are you the kind of guy that wants to think and plan ahead, or take things one day at a time? And for the people that like to plan, we look to the future. We think about what they're hoping for. If they have any concerns or worries, we talk about those things. Not everybody likes to think ahead, and that's okay, but for the people that do, these types of questions are really helpful to get at, not just their questions or hopes for their health, but also for their life. I'll ask this actually, I think the last time I was in our Duchenne clinic, so it was just a couple weeks ago, a sweet teenager, I was there to help with the cardiology conversation, and we asked him just what he wants to do, what he's hoping for, and he shared, you know, he wants to change the world, basically. He wants to go to law school, and it was just inspiring to even get to be with him that day. Yeah, we think ahead a lot.
That sounds awesome. And actually, I had a Duchenne guy share a story with me. He went to a job interview, and they said, well, where do you see yourself in 5 years? And he really hadn't thought about it, you know, but today with the care and all of the treatments and things that we have, we do need to be thinking about what the future is. So when you have finished writing it down, there we go. They're going to go and we're going to grab the pieces of paper and then they're going to deliver them to me on the stage.
Excited.
Yeah, I know, this is exciting. So originally this session was slated for a smaller time frame. So we're like, hey, an activity would be really cool. And then Michaela is going to do her presentation. And then we want to have conversation, right? So feel free to ask questions, raise your hand. We have folks here that can help you and guide you through any questions that you have. And I think they're going to put a mic up here. I forget what they're going to do. But please feel free. This is very casual. You know, you can ask a question, raise your hand. Anybody else have written down? One over here. This is exciting. I can't wait to see what you all think about for the future. What do you hope for in the future, Michaela? You knew I was going to do that.
Oh, wow.
You?
No, I didn't. I'm not prepared for this. So honestly, I don't think too far ahead, much to the annoyance of the people in my life who do. Yeah, my boss will even ask me about things, like, oh, what time are you leaving? And I'm like, for this conference even, I'm like, I don't know. I'll find out right before I need to know it.
Thank you. Anybody else? Do I have everything? Oh, Tess is working on it down here. Oh, sorry. So I know what I hope for the future. I hope for my new college graduate to get a job and get out. That's what I hope. I know that sounds terrible, but I do mean it. I'm really not kidding. Here, why don't I I'll share some with you?
Yeah.
All right, I'm going to go first.
Okay.
My hope for the future is grandkids that are peaceful and happy. And I love that. I got to tell you, grandkids are better than kids. I don't know, I know there's grandparents out there. They're better than kids because if they don't turn out so good, it's not your fault, right? And you get to buy them things and have fun with them and all that good stuff. What do you got over there?
I've got a couple so far, actually 3 out of the 4 here, looking at a cure for Duchenne, obviously. We all hope for that. And I hope as we're going through my presentation, most of the diseases that I, as a palliative medicine physician, take care of don't have cures yet, but we hope that. I hope there is a day when I never have to go back to Duchenne Clinic because we have found many cures for it.
Okay, cool. Actually, I'm going to read one that I love. Where'd it go? To be able to argue with my brother for many more years and to continue to be passionately informed about all he knows. Oh, and become part of the Cure Duchenne genetics team. Sweet. Come see us afterwards. We're in. All right, you're up.
Yeah, I've got a lot here that are living a long life, living long time, but also thriving, good health, family adventures, having as normal a life as possible. Like we heard this morning, there is no normal. All of these are beautiful things to hope for.
Yeah. And what is normal? Normal is super overrated, in my opinion. Real inclusion, amen to that. I don't know so every town has a commission on disability. I am on my town's commission on disability. So I am looking to do this. I'm actually trying to get a grant to install lifts in a school where they have 2 stages or 2 different schools, and anybody that cannot climb stairs cannot get on stage. My son was on stage all the time, so I'm like, so I love that. So if you don't know your disability commission in town, get on it and start making some real change.
Yeah.
All right.
I think I covered most of what's in mine. If we didn't read yours out loud, or I didn't read yours out loud, know that these are very beautiful. I am moved reading the ones I've got.
I know, these are beautiful. I love these future hopes. I hope for happiness for my son and our family. Isn't that what you always want for your children, is for them to be happy, right? That's really what you want.
Yeah, living with someone that loves him for who he is, that's beautiful.
Oh, I love that too. I know Hawken and I were talking about that backstage earlier. Positive change and continued movement forward. Yes, absolutely.
Independence. That's a good hope.
Yes. Truly accessible world. Amen. We just talked about that earlier. Did I repeat that? No, it was something else, wasn't it? I'm getting old. What can I say?
That's okay. Yeah.
You got any more?
I think I covered most of them.
All
Here,
right.
let's see.
So I have one here, fear. I think we all have fear for the future. I know I do. Even those days where maybe I don't feel fear, I can always feel that Duchenne right behind me, tapping me on the shoulder, right? Like it's always there. And sometimes you never know where it will hit you. And I'm going to share a quick story. My son went to a senior ball. He looked amazing, by the way. It was great. So he and his date were standing there. They matched perfectly. Well, it was his friend. I can't say date because he'll get all. So her name was Grace, and he matched her dress, and it was beautiful. And the wheelchair, I saw it in the picture, and then I felt punched in the gut. And the wheelchair has been a part of our life since he was 12, you know, and he's 22. So we've had wheelchair in our life all the time, and for some reason, I hated that chair at that moment. And I think I shared, if you're friends with me on social, I did share that on social media, but it does happen, right? Like you can be mostly positive, but then you have those moments. Yeah. And then medical crisis, yes, that is a scary thought. You know, it's a scary thought for anybody, but especially for someone, you know, that you love. And then some hope. So some hope is better than no hope, right? So, I love all these. You guys are going to have amazing futures. Thank you so much for sharing.
Yeah, thank you for sharing.
Yeah. All right. So what we're going to do now is, if we could cue up the slides for Michaela. She's going to go ahead and do her presentation. It's a little bit different than what we did in Nashville, but it's pretty much the same thing.
I hope so. Yeah. Let's see.
So cue, there we go. Hey, look at us.
There we are. There's me. Okay, I already told y'all about
I love your
myself a little
smile.
bit.
Don't you love that smile? It's so
I've
beautiful.
been told that that's a very cheesy picture of me. I guess that's true. I guess that's true. Oh, thank
It
you.
is beautiful.
Thank you. That's
Thank
very
you.
kind of you to say. Yeah, feel free to stop me at any point, or if you have got questions, like Cheryl said, I think I'd love for this to be informal, but there should be time for questions at the end, so feel free to save them as well. I don't have any financial disclosures. I don't have any financial ties to any of the industries here. I want to thank Cure Duchenne for making it possible for me to be here, and then acknowledge my teammates, my family. Everybody's wonderful that I work with and I care about, and I'm just thankful to so many people, and I think we all feel that sometimes, or we should feel it all the time. Here is the hospital at which I work. This is the Monroe Carroll Jr. Children's Hospital at Vanderbilt. It's over there in Nashville, and like I said, I've been there for about 14 years. It's a great place to work. We're still growing and learning how to take care of kids well. This is a quick outline of what we're gonna talk about today. I've broken it down into the what, why, who, when, and where of palliative care. You all may have had interactions with palliative medicine before. I think most children's, like big children's hospitals, tertiary or quaternary centers across the country have a palliative care team. It looks a little bit different everywhere. I'll talk a little bit about that at the end. But hopefully the things that I talk about are going to be broadly applicable. Here, we're all thinking about palliative care or palliative medicine in the context of neuromuscular diseases or living with Duchenne or Becker muscular dystrophy. But just know that there's more applications. And then we'll talk specifically about the application there as well. Okay. First, I have the what. Now, I think, okay, so let me maybe just see a show of hands of how many of you have a palliative care team that you work with already? A couple, okay, 3. Wonderful. Okay, I'm glad to see that. If I say anything that you don't think sounds right, ask me about it, because I definitely want to get it right here. Okay, so what is palliative care? Palliative care is specialized medical care for people living with serious illnesses, and I'll say and their families, so we care about everybody that's involved or affected by a serious illness. And how do we define serious illness? Well, anything that affects quality of life, so how you live with that condition, or how long that you live, quantity of life. Either one of those or both can be affected in a serious illness. That is an easy, basic definition I think anybody would agree about. And here's what it also looks like. So what does it look like to do this wraparound supportive care? Well, we want to relieve suffering, improve quality of life. We want to do informed decision making. And we want to assist in care coordination across sites of care. You can think of that as communication. We'll go through each of these a little bit to get a little bit more meat on the bones, so to speak. That's what palliative care is. Okay, I'm going to skip that. Okay, I'm going to, in this slide, this is hard to see for y'all, I'm sure. It's probably really small, but this is from a Lancet article on the diagnosis and management of Duchenne. And it shows the interconnectedness of all of the disciplines who are in the medical field that are working with people with Duchenne and caring for them in an integrated way. So that green circle there in the middle, that's the patient, and the blue circle around them is their family. Obviously, that's what we want to be the center of care. Maybe that's not obvious, but that should be the case. That should be the case.
And it's funny, I look at this, and you all probably look at it the same way. So the patient's in the middle, but man, there's a lot of stuff going on around that.
There it is.
And palliative care is just hopefully a part of the whole plan, right?
Yeah, and that's what I wanted to show here. So there at about 4 o'clock is this psychosocial management piece. So the other circles, if you can't read them because they're too small, we've got things like diagnostics and corticosteroid management, orthopedics, pulmonology, GI, cardiology, and then rehab is the top there, and then the psychosocial management, and all the way on the bottom right there is the supportive care. But that's usually where we fit in this interconnected web of care for any serious illness. And then this is directly from this article, that palliative care in Duchenne muscular dystrophy is appropriate for pain management, emotional and spiritual support, and guidance in treatment and medical decisions. So that's the application. I just wanted to show you, I'm not making this up.
Sure.
Right. In my world, I don't do a lot of pain and symptom management for young men with Duchenne. We have other avenues for those boys to get that care. I focus a lot on the other supports, and then the guidance in treatment and decision making, which is my favorite part of my job, and I'll spend a lot of time on that in this talk. So that's that. Now, there are a lot of myths out there for what palliative care is. Like Cheryl said earlier, some people have interactions with palliative care and they might be in negative or sad contexts. I never want to shy away from that, but I do like to emphasize everything we are. But I wanted to just throw this out there in case some of you were just sort of waiting for the ball to drop and can't listen unless we acknowledge that these things are there too. But just so you know, palliative care is not or does not replace other healthcare providers. We'll talk about how we work with them. It doesn't mean that we stop working for a cure or working to prolong life. Absolutely not. Again, like I said earlier, I hope there's a day I never have to. I hope we can cure it in the infancy stages, like we had heard earlier from some of from the neuromuscular specialists. Palliative care is also not the same as hospice. This is probably the most common notion that people have, and I'm not going to spend a lot of time talking about that. If you have questions about that later, we can talk. But for the sake of this, we're going to focus more on what we are. And then we also aren't going to tell you what to do. So this is in the context of decision making. Just know that because the center of that circle is the patient and then their family, unless that person says, hey, I want you to make a decision for me about X, Y, or Z, I'm not going to do that. I'm going to help and guide them into making medical and healthcare decisions that are best for them. So we're not going to replace anybody or take away that autonomy there. Okay, why do we do what we do? This is going to look familiar. Because why we do what we do is also what we do. What is also what we do. So relieving suffering, improve quality of life, we do these things because they're necessary in serious illnesses, right? Anything that affects quality or quantity of life. But we like to remember that humans are not just their physical beings. In medicine, a lot of times we get caught up in the physical, and that's fine. That's good. Health is primarily a physical thing in most cases. But humans are way more than that. And I mean, in this conference, I think, speaks to that. It speaks to the social nature, the community nature of being a human, the cultural pieces of things, the spirituality, the emotional or psychological parts of a human. And having a serious illness, I don't have to tell you all this. It affects each part of these. And so every part of a human can suffer. And by suffering, I just mean discomfort. If it could be physical suffering, it could be any way that you would define suffering, each of these domains can be affected there.
And it can be different, right?
Yeah.
At each phase of our journey. I see so many families out there that, I remember getting the diagnosis. I remember some of the milestones that are sad and uncomfortable. And it's different everywhere. But I really think that oftentimes, and I think in our whole country, mental health needs to really be addressed. I mean, myself included, I see a therapist, thankfully. My son sees a life coach. So I think that, spiritual and mental health and all of those pieces are such an important part of it. It's not just like, oh, you broke your arm,
Correct.
put it in a cast, right?
Yes.
What are some of the things that you're thinking of, and to be able to add that to that circle, I think that's beautiful.
Yeah, just it's holistic care, absolutely. And so we want to, yes, also improve quality of life in each of these domains where we can. It will look different over the course of a condition. And I'll show you a little bit when we talk about when we do palliative care, a little bit more about that too. But this is why we do what we do. It needs to be done. We don't want people living with serious illness to have these impacts as much as we can mitigate. And then why palliative care? So this I mentioned a little bit ago. This is my favorite part of my job. I'm going to spend a little bit more time on here doing some talking about decision making, because I do think it is important. And then talk about that communication piece. And I was actually struck when we had the panelists here this morning, all the neuromuscular specialists, and how much they talked about how much time they give to patients and their families to do that explanation of what's happening, to make decisions together. And I loved that. They're honestly doing palliative care. They're not board certified like I am in palliative medicine, but anytime anybody slows down and helps you make an informed decision, that is palliative care. It's a philosophy of care that wraps around and has lots of different applications to it. But the way I like to think about decision making, and I don't have to explain all of this to you. You all are at a conference where you're exposed to so much of the medical technologies and the advancements in science and the research that's happening that's affecting the people and that you care about. Or if there's anyone in here with Duchenne, I want to make sure I'm not leaving anybody out in here, or you yourself. And so that there are options out there for treatment, management, etc. But I think that a lot of people, especially maybe at first diagnosis or first interaction with the healthcare system, people think that having a serious illness or having to go to the doctor is like getting on a train. There's tracks. The tracks just go straight. You just get on the train and you just go. There's not a whole lot of options. When in fact, it's a lot more like being in a hallway and having to move through that hallway, and there's doors on each side. They're closed. Which one do I open? When I see something in that room, how do I know I want that? Versus if I just walk 3 more doors ahead to the left, or there's a T, and do I go left or right? There's a lot more choices than people think there will be when you're dealing with a chronic condition. And this conference is a great reminder of that. And that's a good thing. That's what's going to push us forward, and ultimately might get us back on the track where we know what we're doing, and we have. But for now, we have choices. Which steroids do I pick? Which gene therapy to go with? All of these things have pros and cons. It might not be obvious what's best to do. How do I use medical technology? What respiratory equipment is best for me or my loved one? How do I know? What does that look like? The young man that I mentioned earlier, I was seeing him because we were talking about advanced cardiac therapies. We were looking at transplant options, and that's not something that we force on anybody, whether they have a serious health condition or not. So helping people understand that they're in a hallway and not on a train track is
and the
important.
direction can change often, right? I know a lot of folks on Facebook or social media, which can be good and bad, as we all know. But I think, someone is like, hey, I'm heading to the doctors for the first time. We just got diagnosed with Duchenne. I'm heading to the doctor. What do I ask? And I'm like, I don't even remember that first day. I don't know about you guys. But I'm like, I think the best part is go to that without any sort of what you think might happen, right? Go into it with you're going to listen, and you're also going to see if you're comfortable with that clinic, that direction. But I think sometimes it's hard you can share, I can say, well, this is what worked for me, but I can't say this is what you should do, right? And I feel like it's important to listen. And I also think it's important to involve the child age appropriate. Like Jake's 22 and he said, I'm not coming to Futures. I couldn't say, well, you have to. He's like, no, I'm not doing it. So I think that I love your train track and hallway, because that is so, Duchenne is not this one straight drive, right? If you've met a young man with Duchenne or Becker, you've met a man or,
Yeah.
or boy with Duchenne or Becker, because they're all different.
Exactly. And so that hallway, I think, sometimes is also in the dark, right?
Yeah.
So then, and it could
The lights
change.
are off.
Yes, exactly. The lights are off, and it could change different phases of illness too. So think of palliative care as turning on the lights, as a support for turning on the lights, and then helping you decide which doors, which hallway turning is best for you, your family, or for when you have an 18-year-old and beyond for themselves. So to go a little bit more in depth with this, and this, I have a friend who. She's really, really great at concrete thinking, and some of you out there might be in this category too, where sort of everything you say is automatically applied to everything in her life, and the abstract is a little bit more challenging for her. So whenever I'm like, I personally love philosophy and theory, and I'm up here, and I would have to say, hey, abstract alert, like I'm about to be up here for a little bit. So for those of you who are really good at the concrete, this is a little bit of your abstract alert, but I do unfortunately think that living with a serious or chronic illness is kind of like a terrible game of would you rather. You've all probably, would you rather, if you have kids, it's always something kind of gross, would you rather lick a toilet or eat the trash, eat something out of the trash can and that kind of thing. And some of them are more fun or silly, would you rather be invisible or be able to fly? That's a kind of a fun one. Some are more practical. Would you rather sit in traffic and get home quicker or take the back roads, have no traffic, but it takes a little bit longer to get there? That's the one I think about every day, driving home from work. And then there's also health-related would you rathers. This is sort of rubber hitting the road here, I guess, pardon the pun, but would you rather experience the effects of the disease, or would you rather experience the side effects of the treatment of that disease? And then the trickiest would you rather live a longer life with some level of suffering or a shorter life without it? And these are terrible would you rathers, right? The answer is neither. I don't want any of this. I don't want to have to would you rather, but when you have a serious illness, unfortunately we are faced with some would you rathers like this. And as you are looking at these, some of you maybe automatically were like, oh, obvious, 1, 2, 3, 4, I know exactly. And some of you probably thought when you looked at these, like, wait, okay, it depends. And it's the it depends that I think matters most in all of these healthcare decisions. Okay, like what side effects are we talking about, right? That matters. What treatments am I going to have to, what are the treatments, or how long are we talking here? And when you're talking about sitting in traffic, 5 minutes might not make a big difference, but when we're talking about like lifespan, that if it's years, it might make a difference as opposed to a shorter period of time.
And with all of the newer technology with gene therapy and things like that, you need to really think about,
Yeah.
Should I do this? Should I do that? When Mike Kelly and I do a lot of one-on-ones with families, there's so many decisions, and that's wonderful, right? When my son was diagnosed, there was nothing. But to have so many decisions is wonderful and scary as heck as well. Should I do this? Is this the right thing? If he's just going to throw up for a little while, maybe that's okay.
Right.
But like if we need to look into, other, organ issues, then maybe not, right? So you're right. They're kind of crappy decisions, but yet.
Yeah, we're facing them. And what palliative care does is we want to help people when they're faced with some of these things. I mentioned a few earlier, steroids or gene therapy or respiratory equipment or whatever it is, whatever the decision that you or your son or your loved one or yourself maybe at one point are facing, we want to help you figure out the why behind those decisions. So I love this slide, and I think Cheryl likes it too, but it's the why behind the decision, those values, beliefs, your worries, your hopes, the things you want for your future, like we did in that exercise. All of that is your, I'm going to say this, your water, and then I'll explain it. So fish don't know what water is. There's a famous joke about this. There's a fish swimming by some other fish, and the one fish says to the other, hey, how's the water today? And those two fish are like, I don't know, what's water? They don't recognize that they're swimming in something that impacts their whole life. And maybe you experienced that on the previous slide of if the would you rathers were automatic to you, and I would just say take a second to slow down, and the thought process behind how you chose your would you rathers is the water with which you're making decisions or with which you're living your life. And until you know what that is, I think that some of these decisions that you're going to face in whatever situation are going to be a little bit trickier. But once you know what's important to you, once you have that defined, and once you have think through that, then it's a little bit easier to make all these decisions. And that's where a palliative palliative care comes in, because this is where we can help ask those questions, take time, and have that sort of more guided experience in thinking through these things together. And then we also have the medical piece, so where I can understand. I can't understand it like the neurologist that we're sitting up here, but I definitely have a good handle on the medicine of a lot of the diseases that I see. And so I can help a family understand what they're choosing and then help them understand why they're choosing it, and we can work together to find a good.
And this was my favorite slide because we all swim in our own water. I use it all the time, just so you know, at home. I'm like, oh, sorry, I was swimming in my own water.
Yeah. And
I wasn't thinking about your water. And so I love this, and I'm going to tell you, you're all going to be doing the same thing when you get home. Am I swimming in my water?
Yeah.
Or your water?
Yeah, because we don't know what each other's water is. Anybody that's ever like met some, you know, like you have personal interactions, right? You make assumptions about what they're thinking based on what you're thinking. That's what your water is. It's your personal culture, your personal beliefs, your personal values. It's how you see the world. And we want it just to expose that, so then we can talk about it and make good decisions for health. And then it's important to not just know that, but also know that your physicians are swimming in their own water, right? So this goes back to the we don't want to tell you what to do, because a lot of people do ask their doctors, hey, what do you think I should do? That's a great question. It shows that there's a lot of trust and a good therapeutic relationship there, but you don't, trust me, you don't want your doctors making decisions based on, for you or your son, based on their water, right? You want to make it based on your water, and that's what palliative care can help with. And then communicate it to everybody else. That's the picture there, that just on the right there, that communication is complicated. I don't have to tell all of you that. But sometimes we are the one that gets to know a patient really well, and then we can go to their neurologist or their cardiologist or whomever, if they're in the hospital, help with that coordination. I say, hey, this is what's important to so-and-so. This is what he's told me before about what's important to him. As we're looking at his health, as we're looking at this hospitalization or this next step, here are the things that we want to prioritize. So that's what that can look like. And there's a name for that in medicine. It's called shared decision making. Some of you may have heard that term. It's the bridge between what's important to you, your water, and the medical choices. I love this picture. It's a bridge in Vietnam. I think it's at a resort. But I would love to go there one day. But it's these hands holding up the bridge, and I think of palliative care, palliative medicine, like the bridge, like the hands holding up the bridge, helping build it between. So that's my favorite part of my job, getting to do that. So that's why I spent a little bit more time on that. And
I love that
I
picture
just like
too.
the concepts. Yeah, it's beautiful. Okay, recap. Here's what we do, and we do it because we know it needs to be done. We want to relieve suffering, improve quality of life in every domain of humanity. We want to facilitate informed decision making and then assist in that communication across different sites of care. And like Cheryl pointed out, and is so good at reminding me to say too, that this can change throughout the course of a condition. Sorry, I repeated this here. Okay, who? So who does palliative care? Basically anybody can do palliative care. So a little bit more about my field though. So I am a palliative medicine physician. So that's like saying that I'm a cardiologist or a neurologist or a pulmonologist. I have extra training in palliative medicine. But palliative care is more of that philosophy of care. So like I said, the neurologists up here, they're doing palliative care when they slow down and ask you what's important to you. Social workers, they acknowledge social workers. Yes, shout out to all the social workers out there. Social workers are doing palliative care when they support a family whose child has a serious illness. Spiritual support, psychological support, all of these. Anybody that helps sort of soften the experience in a condition that is serious technically is doing palliative care. It just looks different in different situations. And then palliative medicine providers are actually board certified and trained in doing that specifically. But any part of the human that needs to be addressed, a person that helps with that is doing palliative care. Child life is a great one, especially for siblings. I don't know if there's any child life people here at this conference, but they're wonderful. Their specialty is helping kids and kids and any kid, I guess, understand and cope and with having an illness. So
we did have a sibling breakout too.
Oh yeah, great.
Yeah,
Perfect.
sibling breakout, and I think there's a second part of it too, because again, it's the whole family.
That's
right?
great.
It's
Yeah,
not just the patient.
exactly. Yeah, I actually got texted a couple hours ago to ask if I was coming to see anybody at our Duchenne clinic at Vanderbilt today, and I was like, no. And then she was like, oh, I meant to ask child life. It wasn't you actually wanted. So I was like, that's great. Well, hopefully the child life specialist is there. Okay, when can palliative care get involved? The short answer is any time from diagnosis on, when anyone's diagnosed with a serious illness. So that's the quick answer. The longer answer is that it depends. So that the top bar up there, let me see if I added it. I did not add it, but that's okay. My updated slide deck, which I forgot to send Cheryl, has like a big X over the top half of this screen, because that's not the way that we think about palliative medicine anymore. But for those of you who maybe have experienced it with other loved ones in a condition like this, is sort of the classic of, well, let me back up for a second. So palliative medicine was invented or discovered, however you want to say it, in the 60s from a nurse who took care of cancer patients. And in that situation, in that time, there was this sort of, you treat the disease as far as you can. There's a point at which you run out of treatment options, and then you do palliative care. So it was this very binary, you're either doing disease-modifying treatment or you're focused on support and addressing the whole person, and so you're not taking things into account that impact them as a whole human. So there should be a big red X over that top one. The bottom one is an example of how palliative care can look. So again, and I just should have said this earlier, but time is going across there. Y'all are smart, probably figured that out. But sometimes with a serious illness, we're doing a lot of disease-modifying treatments at the beginning, and as time passes, maybe we just have fewer of them, or for whatever reason, there are fewer of them. So palliative care can get involved at the beginning, and then maybe palliative care involvement increases as time goes on. Or it could look like this. We do disease-modifying treatments from the beginning, all through the disease process. Palliative care might get involved at the start, and then might expand as time passes, as health changes. I've seen some of these graphs, and maybe next time I'll add it in there, but sort of like a up and down line. Whoops, let me go back. Of how much we're involved. So we usually, the way I function in my hospital is we usually at a decision point is when we get involved. So there might be not a lot of palliative care involvement, and then we come to a decision, and then we get involved, but maybe then we make the decision, so we go away for a little while. And so there is this up and down pattern to it, but just know that palliative care can be consulted or involved at any point from diagnosis on.
And I have heard families that have talked about palliative care that is part of their multidisciplinary clinic, is that you're needed here and there,
Yes.
but maybe not all the time.
Yes.
So when they're trying to make decisions, then you're
Yes.
invited, and then maybe you don't see them for a little while, and then you go back in. But how beautiful would it be to have someone that whole time to be helping you, guiding you, loving you, getting to know you,
Yes.
and all those things.
Absolutely, and the relationship, I think, is most of the journey with palliative care, letting us get to know you and your family, or more importantly, your son, and that let that relationship develop over time. I mean, one of my favorite patients ever was a Duchenne's patient, and he just taught me so much, and he was, I think, the perfect example of what it looked like to build relationship, and it was just great. He'll always be one of my favorites. But yes, the relationship over time is the key. I'm going to skip this for now. We can come back to it, but this is sort of a storyboard, if you'd like, or not storyboard, but journey board of sort of when palliative care can get involved. I'm not going to spend a whole lot of time on that, but it is kind of a nice visual. Okay, let's get right to where palliative care, and the answer to this one is anywhere our patients are. So we, at my hospital, we see patients in the hospital, we see patients in clinic, and then we also sometimes take care of patients at home. This map that you're looking at is a little outdated. It's about 10 years old. I could not find something more recent, and that's okay, because just imagine there's more green dots. But this was programs, pediatric palliative care programs that were reporting to this certain registry about 10 years ago. Those geography buffs out there will notice Nashville is not even on here, so this was pre my program. I know, it is.
You're not even a dot on the map.
I know,
Come on, man.
I know. I should have put a big star there. But there's quite a few in Texas, as you can see, and that is still the case for those of you who are in this area. I know there's programs in Houston and Dallas, and Austin.
Yeah.
And Austin. In Austin, and yeah.
And every other city.
In every other major, yes, but hopefully you can see. And so, yeah, we go where our patients are, and it's great. Every palliative care program is a little bit different, and I think I talk about this at the end, but just know that we are around and want to help. Now, as you get older, there are a lot more adult palliative care programs. Most hospitals in the country have some sort of access to palliative medicine. And so if you're interacting with the adult healthcare system and not just the pediatric one, you probably have more options for palliative care. And they're doing what we do, they just apply it a little bit differently. It's all the same philosophies. But this is pediatrics. Okay, so what can you expect? So this is now bringing it back down to just the nuts and bolts of what does it look like, or what can you expect from a palliative care consult or involvement for those with Duchenne. So it does depend on a couple things. Your institution, I've already alluded to this, or you maybe even just been explicit with it, that what palliative care looks like at your institution might be different from what it looks like at mine. And that's just because we are limited in resources. You know, there are not a lot of me's out there, a lot of people doing palliative medicine. And so how big your team is can vary. Whether they see patients in the clinic is actually one that I think is pretty common. A lot of palliative care teams in pediatric hospitals only see patients in the hospital, which is kind of a bummer. But a lot do have capabilities to do clinic. Where I did my fellowship up in Akron, Ohio, we did a lot more pain management than I do at Vanderbilt. And that's just the way that our team is set up. In different capacities. So what you can expect from palliative care involvement does depend on your institution a little bit. It could depend on age and health status. In my updated slides, I kind of combined these because they can sometimes go together. And this goes back to that decision point. You know, if we're getting more respiratory infections or we're having different effects of our cardiomyopathy, that might bring up decision points where someone might think, hey, let's get palliative care involved. And like Cheryl said, you know, there are some people where it's like, hey, we need you for a decision. We've got the decision, and things are kind of all rolling downhill in a good, you know, rolling good in a good way downhill. Like just on the train track is what I mean by that. And then, you know, as things change, we might get more involved. So what you could expect might depend on those things as well. And then the thing I didn't add on to this one, but I think it also depends on you. So it depends on each person, so each young man with Duchenne or their family. There are some families that want to talk to us a lot, that want our input on a lot of things, and we'll see them a lot. We'll follow them a lot more closely. And there are others who are, you know, great, it's nice to meet you. What you're doing is awesome, but we'll see you when we need you later on. So it can depend on the family too, and that goes back to that just family-centric, patient-centric model of care for palliative medicine. So I'm saying all this to say, if this all sounds awesome, great, but what it looks like at your institution might just be different applications. But go ahead and ask. Let me see. So this is back to, okay. This is what I usually do, though, in my visits when I'm meeting a young man with Duchenne in clinic. So this is kind of my first visit script. So the way my team does this is we usually try to meet young men in their late teens. Sooner, if there are concerns sooner, specifically health status changes or decisions to make. But we try to aim for 16. And then that gives us a little bit of time to feel things out and build relationship before we're hitting that 18 mark, right? You know, that now he's never on his own, but you know, legally, he's at the age of majority. So that gives us some time to build that relationship. And I want to hear who he is. I want to know him. I want to tell me about yourself. What do you like to do? What do you want to study in college? What's your favorite video game? All of those types of questions are great. I like to ask, tell me what it's like to live with Duchenne. I meet a lot of young men, and they tell me lots of different things. Like, is there anything good about it? What are the challenges that you find living with Duchenne? And that usually lends itself then to a conversation about health. And this goes back to the future. You know, are you the kind of person that likes to think ahead, or are you the kind of person that likes to take things one day at a time? And then if you're a thinker aheader, when you think about your future health, what concerns, questions, worries, hopes do you have? Anything like that. I like to ask either families or the young man, and sometimes in tandem, because we're usually doing all the visits together, is, you know, how are your heart and your lungs doing? What are the other doctors saying about your health? That's important because we can't make decisions with false information, right? So if there's misunderstandings, you know, that the other doctors that I work with maybe are not interpreting their jargon well enough at that particular point or in the way that family needs to hear it, then I will say, okay, well, I'm going to flag that because I've heard something a little different from your other doctors. Can I go get your cardiologist and we can talk about it together, what's actually going on? And be that broker of that communication, that complex communication like we were talking about earlier. And then this is a big one for young men approaching 18. How do you prefer to make decisions about your health? So I think that most, one of the physicians up here earlier said, when she asks about constipation, the young man always turns to his mom. But I find that to be true as well. But I want to know. I'm totally fine if every young man with Duchenne I met said, talk to my mom, talk to my dad, talk to my caregiver. That's fine. I just want to know that that's really what they want. Because I want to empower them in their health. I want to empower them to know as much as they want to know, to think ahead as much as they want to think ahead, to not be pushed too far ahead if they don't want to be pushed too far ahead, but to know that they have the power and the right to have their own autonomy in this. And then most of them, yes, absolutely. My mom, my dad, my whomever, my brother, I want them involved. And so then we absolutely will involve that. Sometimes we even go so far as to making that legal. Once they hit 18, it's helpful to sometimes have that on paper. So we'll do some paperwork that says, if, I want my mom to be involved in my decision making legally. And then that goes to that last question too. And I think every adult should answer this, whether you're living with a serious illness or not. Who knows you well enough to make decisions about your health if you can't? This is just a good one to have. Mine's my mom, in case anybody needs to know. Love moms. Okay, that's how my visits go. Again, what you should expect at your institution might be a little bit different, but this is my approach to these first visits. And then we go from there, and then we're just building relationship over time. Okay, so let's say all this sounds great and you would like palliative care to be involved at your place. Your first step is going to be to ask your DMD providers if palliative care is available. It should be in some capacity. But sometimes it's even just helpful to have, we have a nurse coordinator on our team, and we have a conversation. She often calls families and kind of explains what we do, and it starts just with an interaction with our team, and then we're aware of that family in case they have to come to the hospital or something changes. So that could be a first step.
Just one sec.
Yeah,
so
please.
one of the things that, so we go to UMass, and that was one of the questions that I asked. A lot of times folks will travel. Mm-hmm. So say they live somewhere, but they go to a different clinic.
Yes.
How does that connection happen where they don't live close, they travel there? So that's I don't know if you guys thought of that question, but that came from me personally.
That's it, yeah. No, I'm glad you
we
said
can get them involved, we live there, but what about all the folks that travel to go to their clinic visits?
Yeah, that's a great thing. Actually, I would say if you travel to go to a clinic, a DMD clinic, I would say that would even be a reason to ask ahead of time. Because sometimes if there's at the institution that you're going to, they might need to plan their day and their schedule and to meet you and to plan to meet you. We also do a lot of telemed visits within the state of Tennessee, so that's an option for us. But we get families from Alabama and South Carolina and Kentucky, yeah. So I would say that's one of those things that was just going to depend on your institution. It's going to be a conversation of what's available to you. I was taking care of a young man with Duchenne who comes to our clinic from, I don't remember, somewhere in South Carolina, and that's where he goes. He gets hospitalized there, but they come to our clinic for all their care, and there was this sort of back and forth about which palliative care team should they see. So it can be a question, but I would just say keep it an open conversation. Explore telemed. I think probably regionally that might be more available to some than others. But yeah, it couldn't hurt to ask. Did I answer that question okay?
Yes, ma'am.
Okay. Great. Okay, you may still need to educate your providers that palliative care is not that sort of, we do all this stuff and then at some point we run out of stuff and now we're doing palliative care, that it's more of this, we can do both at the same time together. If you have younger, I'm not going to be, I don't want to categorize anybody unfairly here, but typically because of palliative medicine's roots, it's usually older providers and people who've practiced in sort of before all of the recent developments who have that mindset. So a lot of the younger people, younger trainees are growing up in their training with this mindset that palliative care can be involved at any point. But you might need to gently remind your neurologist or cardiologist, hey, this doesn't mean it. All this means is that we want an extra layer of support for our family as we're living with this serious illness, hopefully for a very long time, and that's okay. And then let's say you get a little pushback or that palliative care just isn't as available as we would like it to be at your institution yet. There are other ways to get resources. So like I said, as a philosophy of care, lots of people do palliative care, social workers, spiritual care, all of these neuromuscular physicians that were up here, they all were doing palliative care. So your other providers might be really good at this, especially if they're the ones help like with the specific decisions, like about the gene therapies or things in advocacy groups like Cure Duchenne's have lots of wraparound support and resources too. So use what you can when you can to get sort of the philosophy of palliative care applied to you and your family, for sure. Okay, I think that's all I have, and we're happy to take questions, happy to clarify anything. If I said anything that was confusing, it was probably because I was swimming in my own water and didn't realize
Not your water.
and didn't realize that I was saying something that didn't make a lot of sense. I think doctors do that a lot. They swim in their own water.
Yeah,
very
and
well.
Michaela will be around tonight
Absolutely.
as well. I'm making her stay for the keynote tomorrow, so
I want to stay for the
she'll
keynote.
be here for that. So, feel free. She's pretty approachable. You can ask her any questions. But does anyone have any questions in the audience for this? Because we do have time. Yes.
Okay, sticking with the fish in the water.
Yeah.
Which is such a great visual. Really appreciate that. So I'm going to assume that when a boy is diagnosed, he's still swimming in his mom's water. And maybe that's a wrong assumption. But if you're getting diagnosed between 2 and 5, you may not have You may not have a lot of your own water yet.
Yeah. Oh, yes.
Or it's definable. So